Good afternoon and welcome. I'm Chris Fanta. It's my pleasure to welcome you to Asthma Grand Rounds, the first of our calendar year 2012, and also the first in which we're doing live webcasting. So to members of the audience who join us at their computer terminal, thank you for joining us. We haven't yet arranged that you can send in your questions live, but I would love your feedback, and so please just send it to asthma@partners.org, and we'd be delighted to get your feedback about the webcast, as well as those joining us by video conferencing, as usual, at Mass General and North Shore and Leahy Clinic. Good afternoon. This is also the time of year when we start to plan next year's, that's 2012, 2013 Asthma Grand Rounds programs. So I'd very much welcome your input about speakers and topics that you'd like to hear about. Maybe you'll grab an evaluation form on your way out and just make note of interesting ideas you have for next year's program, or you can send an email as well. So today we're delighted to have as our special guest Dr. Ben Gaston, who is really a colleague and friend to many in the audience today. He trained at Children's Hospital. He did much of his research with Jeff Drazen and Mary Ellen Wall here in Boston. He is now professor of pediatrics at the University of Virginia Medical Center. He's an active investigator in the NHLBI Severe Asthma Research Program. And we're very delighted to have him here today to talk to us about airway biochemistry of severe asthma in adults and children. Dr. Gaston.
Thanks very much, Chris. It's a great honor to be here. Can you hear me? I have two mics on. I'm balanced, and one here. So can everybody hear me okay? Okay, terrific. All right. Yeah, it's a great honor to be here, and I really appreciate the invitation. I don't know how I wound up on this short list, but it's wonderful. I think maybe I'm the token pediatrician, but that's also an honor. So I hope to say some controversial things today, and then maybe we'll have some time at the end for questions and for you to argue with me. That would be wonderful. That might be the best part of the talk. It's wonderful to be back. I have a couple of relevant disclosures, intellectual property regarding some of the things that I'll talk about, geosinover reductase inhibition, and I have IP and ownership in Respiratory Research Incorporated and Airbase LLC, both of which are involved in breath condensate analysis and also in neutralizing the airway pH. And I will talk some about data regarding those issues. Over the course of the next hour, I'd like to say 5 things, and these are they. This, by the way, is something that Jeff Drazen always told me to say, and that is, say what you're going to say, and then say what you have to say, and then say what you said. So that's what I'm going to do. So first, I'm going to review a little bit of what we know from the Severe Asthma Research Program. As Chris mentioned, we've been involved in that now for 10 years with Elliot, so with regard to the SARP, it's taught us a couple of things. First, that bronchoscopy can be safe in severe asthma, and secondly, more importantly, I'll spend more time on the second, that asthma is quite heterogeneous. The second, I'm going to be a little more controversial and suggest that some of the broad heterogeneity of asthma worldwide may have to do with acetaminophen use and may help to explain that phenomenon, and we'll talk some about whether that's the case and why it might be. The third thing I'd like to say is that severe asthma heterogeneity makes it poorly suited for unbiased analysis, and hopefully this will be the most controversial thing I'll talk about, and I'll spend some time on it. The fourth is that a medical or biased model will be the best approach for managing severe asthma in particular. And finally, I'd like to dive into a little bit of an example. I'll talk about 3 examples, but at the end I'll talk specifically about the example of high S-nitrosylglutathione reductase activity as an example of the medical model of managing severe asthma. So to begin in the beginning, I think most people in this room with a lot of familiarity with asthma know the Wenzel-Busse definition of severe asthma involving at least one of 2 major criteria, high-dose inhaled corticosteroids or oral corticosteroids for more than 50% of the year. So these are really steroid dependent or steroid refractory asthmatics, and that's critical in terms of how we approach management. We also ask that they have some minor criteria evidence for ongoing symptomatology. But these are patients for whom the conventional approach to asthma isn't working very well. You could argue that this is the corticosteroid-resistant asthma program. I'll let you figure out that mnemonic, but it is what it is. So our overall enrollment was over 1,000 adults and 281 children. Of these, 568 had severe asthma. And we, for various reasons, enrolled controls with non-severe asthma and normal subjects. And so what have we learned from 10 years of the SARP? First, that with the appropriate protocol and experience, bronchoscopies can be done safely in severe asthma, both in adults and children. That asthma is heterogeneous, and most importantly, that the determinants of the heterogeneity provide opportunities for treatment in severe asthma. So let's talk about bronchoscopies in adults just briefly, because this is a very asthma-interested group. I think the last point is the most important one, and that is that all of the bronchoscopies done on severe asthma patients and non-severe asthma patients and controls in the SARP were done by very experienced bronchoscopists following relatively rigid protocols. And I think it's important not to take away the message that anybody can do a bronchoscopy on somebody with asthma. But if you do it properly, it can be done safely. We did 436 bronchoscopies. There were no deaths. There were 7 unexpected admissions for asthma exacerbations. We had a lot of expected admissions, in particular the people with very severe asthma, as defined in the lower right, were routinely admitted as an expected admission. But as far as unexpected events, there were 7 unexpected admissions. Change in FEV1 was similar in all the asthma groups. With regard to the very severe asthma group, we asked that before providers could go on and bronch very severe asthma, they had to demonstrate that they had done it safely with supervision in 7 patients with VSA. In children, for children over 12 in St. Louis, it was part of the standard SARP protocol to do bronchoscopies on those. For children under 12, there were clinical indications only. We had no deaths and no significant SAEs. The indications were primarily persistent wheezing refractory to therapy, wheezing with daily productive cough, or persistent lung abnormality on chest X-ray. And these were following the guidelines suggested by Jocelyn Juste from Paris, who looked at over 6,000 children with asthma, had done bronchoscopies on 90 of them, and had found a very substantial number of significant abnormalities and abnormal cultures on those children. But again, we also, in children, had a very strict protocol. Okay, so the bigger thing that we've learned from SARP, besides the fact that we can do bronchoscopies, is that asthma is a very large heterogeneous population. It's obviously more common in allergic people, but up to half of many populations have allergies, and only about 10% of patients have asthma. Depending on ascertainment methods, countries, it affects over 10% of the populations in many countries. This is Canada, very typical, with an increasing prevalence. And I would say, and here's my first probably quite controversial statement, that it's been hard with unbiased analysis to find genes of general relevance to asthma, much less to severe asthma. In other words, if you do unbiased analysis of 10% of the population, you're going to find some genes, but they're not going to be genes of general relevance to most people with asthma for the most part. And so a lot of people went into the SARP thinking that we would find the severe asthma gene. I can't say that we have, because it's such a heterogeneous population. Increased asthma prevalence is international and not linked to a specific genetically determined group. What are the determinants if that's the case? Well, air pollution, I think these data from California reiterate an important study from Philadelphia that as air quality has improved, asthma prevalence has increased. Certainly, asthma is more common in patients coming from a low-income background. These are data from Ohio. I think this is fairly universal. As you go around the country and around the world, you see this tendency. But patients in a low-income environment are not necessarily those exposed to better hygiene than those in a high-income environment. So there are ongoing issues with the hygiene hypothesis, although there's undoubtedly some truth to the idea that being in a hygienic environment is the cause of asthma. So the Isaac study focused on children and went around the world looking at these various determinants in various locations to try to synthesize a more unified story to explain the increase in asthma in children. And they used a very simple instrument, the Isaac questionnaire. I think you're all familiar with that, and went all over. In the initial study in 31 countries and then later in 50 countries, and said, what are the common features of children with asthma in different groups, in age groups? And I think everybody was surprised, including the Isaac investigators, to find that acetaminophen use was very strongly associated with childhood asthma. And this is in very large multivariate analysis accounting for a variety of different cultures and backgrounds and factors. Obviously, the huge weakness is that it's really only using the Isaac screening questionnaire to make the diagnosis. Ultimately, they went back and went to teenagers and used a videotape saying, okay, this is what an asthma attack looks like, this is what asthma looks like, does this ever happen to you, as the criterion for deciding whether or not the person had asthma. But using the Isaac questionnaire in over 200,000 children, acetaminophen use in the first year of life was associated with asthma symptoms at age 6 to 7. Subsequent prospective study on a newborn cohort in Budajira, Ethiopia, looked at acetaminophen, hygiene, and also Helminth parameters, looking at stool, and found that the most robust association was with acetaminophen use. And there was even an element of a dose-response effect, such that the odds ratio for using 1 to 3 tablets per month and having wheezing was less than the odds ratio if you used 4 tablets a month, as opposed to never. So the comparator there was never using acetaminophen. And in the Isaac study, in the original Isaac study, what was called severe asthma, which was defined here as symptoms worse during sleep or wheezing 1 or more nights per week, or wheezing severe enough to limit speech, or 4 more attacks of wheezing per the last 12 months. So certainly not what we would consider severe asthma in the SARP. But per their definition of severe asthma, the odds ratios were quite high for use of just generally medium versus none and high versus none of acetaminophen or paracetamol. So what's up with this? This is a follow-up study of 300,000 teenagers using the video demonstration of wheezing in different countries, looking at odds ratio of acetaminophen versus none. So Steve Holgate wrote a nice editorial in the Blue Journal, very articulate, considering all the possibilities, that I think everybody would assume that acetaminophen is just a marker for viral infection. But by the same token, other antipyretics didn't fall out as being relevant to later onset wheezing. That it depletes glutathione, and GST polymorphisms have been associated with asthma in some populations, but not so universally. And that maybe acetaminophen impairs the glutathione response or the immune response to viral infection. And all of these are certainly plausible. But I think there's a biologically plausible explanation that was put forward by John Hunt a few years ago. And that is this: if you have somebody in your MICU with Tylenol overdose, and you ask for a Tylenol level, the way that they will assay Tylenol in the lab is to subject the molecule to this reaction, which is acid nitration. So you make nitroacetaminophen in the context of acidification, and this is yellow.